Hello, my name is Yutong. Here is an introduction of the treatment planning research defined by the BiRT protocol. This presentation is going to give you an overview of the background and aims of the BiRT protocol. We're going to also introduce you the hypoflame style dose prescription plan A, the BiRT-based dose prescription plan B, and the BiRT-based dose prescription under the assumption of the perfect tumor tracking, the plan C. First, the overview of the background and aims. This study requires production of three treatment plans for three representative patients. The Plan A, a homogeneous integral boost to the PTV2 DAL, which is a volume expanded by the dominant intraprostatic lesion, the DAL volume, by incorporating the maximum setup errors. Through the Plan A, we want to figure out what is the highest boost level that a uniform boost can achieve. The Plan B, a BiRT-based heterogeneous integral boost to the PTV1 DIL, which is a volume expanded from the DIL volume by incorporating both random and maximum setup errors. That's the reason why the PTV1 DIL is bigger than the PTV2 DIL. Through the Plan B, we wish to investigate what is the maximum integral boost level that the BiRT-based dose prescription can achieve. Therefore, the first aim of this study is, by comparing the Plan A and Plan B, we want to investigate if the BiRT-based dose prescription, which inclusive of the setup and intrafraction motion uncertainties of the DAL, can reduce the dose to the OARs and/or increase the tumor control level for the DAL relative to the homogeneous dose prescription that the boost volume only covers the setup uncertainties of the DAL volume. Under the ideal intrafraction motion tracking, which means there is no intrafraction motion resulted, the Plan C includes a BiRT-based heterogeneous integral boost to the PTV2 DAL and a homogeneous dose prescription to the PTV2 prostate, which is an expanded volume only covering the prostate setup errors. Through the Plan C, we wish to figure out the maximum integral boost level that BiRT-based dose prescription can achieve under the assumption of the perfect prostate tracking. By comparing the Plan B and Plan C, we intended to investigate under the perfect prostate motion tracking how much integral boost level can be escalated. We will also provide a virtual CT which consists by the bone, the muscle and soft tissue, and the fat. The OER structures provided along with the virtual CT are the bladder, the rectum, the femoral heads, the urethra, the small bowel, and the pineal bulb. We will also provide the contour of the prostate, which is blue contour over here, and the dominant intraprostatic lesion, the DAL contour, the red contour over here. They will be named as the GTV DAL and CTV prostate. The hypoflame style dose prescription, the Plan A. The PTV1 prostate, which is a volume, includes the prostate setup and intrafraction motion, is defined by giving a 2.4 mm margin in anterior, posterior, left and right direction and a 2.0 mm margin in superior and inferior direction to a CTV prostate control. The PTV2 DAL, which only includes the setup error of the DAL, is defined by giving a 1.2 mm margin and a 2.0 mm margin to the GTV DAL control. The Plan A is prescribed with 35 gray in 5 fractions to the PTV1 prostate, which is the purple region over here, and a focal boost up to 50 gray to the PTV2 DAL, which is the orange volume over here. By gradually reducing the PTV2 DAL prescribed dose from the 50 gray, the maximum achievable integral boost level defined by the D99, the maximum dosage received by the 99% of the volume, can be obtained. Next, the BiRT-based dose prescription, the Plan B. The Plan B applied the PTV1 prostate as same as the Plan A, and also the PTV1 DIL, which is the volume includes the both setup and intrafraction motion of the DIL by giving a 2.4 mm and 2.0 mm margin to the GTV DIL. The Plan B includes a structure-based dose escalation to the PTV1 DIL, which is different to the PTV2 DIL by 4 defined structures, and we named them as CTV1 DIL 1 to 4. They're prescribed with the dose from low to high. So Next, because we want to investigate the highest achievable boost level, so through the order from the high to low according to the labeled boost level in the contour's name, we can apply the corresponding four contours to investigate the maximum achievable boost level. A series of potentially applied structures were provided to cover the boost levels from 36 to 50 gray, in which the planner can select the correct four contours to conduct the heterogeneous integral boost. Because we want to investigate the maximum integral boost level, so we're going to start from the 50 gray. Therefore, we're going to select four contours for structures named with P3B 50 gray. The P3 means it's patient 3. There are totally 3 patients, patient 1, 2, and 3. The B means it's plan B, and 50 gray means it's defined boost level. And the name here means the prescribed dose level to each of those structures. Therefore, we can conduct the heterogeneous integral boost by the four structures over here, and we're going to see if there is any dose constraints has been violated. If the dose constraints has been violated, we're going to choose four structures with lower boost level, which is 49 gray. We're going to iterate this process for several times until the dose constraints has been satisfied. Assume we can achieve a 40 gray boost, then the four contours named with the corresponding boost level should be picked. In this case, it's going to be P3B 40 gray. And please remember to rename the contours with the CTV1 DL1 to 4, and please include the prescribed dose over here. Therefore, in the plan B, the PTV1 prostate is prescribed with 35 gray, and the rest of the four structures over here are going to be prescribed with a gray value indicated by its name. The BiRT-based dose prescription under the assumption of the perfect tumor tracking, the plan C. Under the perfect prostate intrafraction motion tracking, the random error is not considered in the plan C. Therefore, in this case, we can apply the PTV2 prostate and the PTV2 DL. The PTV2 prostate only includes the setup error of the prostate. It was generated by giving a 1.2 mm margin and a 2.0 mm margin to the CTV prostate. The plan C includes a structure-based dose escalation to the PTV2 DL by 3 defined structures. We name them as CTV2 DL1 to 3. And as same as plan B, we wish to investigate the maximum achievable boost level. Through conducting the treatment planning with the contours from the different boost level, the contours labeled with the maximum achievable boost level can be determined, just like what happened in plan B. So after renaming the applied 3 structures with CTV2 DL123, the treatment plan in the left figure will result. In plan C, the PTV2 prostate is prescribed with 35 gray, and the rest 3 structures CTV2 DL123 are prescribed with a gray value indicated by its name. The required data package can be downloaded from the Google Drive. Secure access will be provided to confirm the study participants. The data package consists of an abstracted pelvic CT, which is a virtual CT reproduced, the structure size of 3 patients, the forms to be completed with specific planning information. You can also find a flowchart of treatment planning over there, a BiRT protocol which contains detailed information of this treatment planning study, and this video also along with the PowerPoint of the video. Thanks for watching. If you have any questions or comments, please contact me by the email address over here. Thank you very much.